Hi friends, greetings of the day. Today we will discuss about the disorders of sexual development, also called as DSG or Ambiguous Genitalia Part 1. Okay. Uh, First we will see the normal physiology of sex development. Okay. In fetus till 6 weeks of gestational age, the gonads are bipotential. Gonads are bipotential. Can develop into male or female. Can develop either into male gonad, that is testis, or into female gonad. Okay, they are bipotential. Till 6 weeks of gestation, the gonads can develop into both. Can develop into either male or either female. Okay, that is either testis or either ovary. These bipotential gonad is influenced by some genetic factors like WT1 gene and SF1 gene. So these for the formation of these bipotential gonads also there should be formation of bipotential, or they are also called as primitive gonads. There should be some genetic factors like WT1 and SF1 genes. Okay, and for the bipotential gonads to become into male gonad, that is testis, there are genetic factors like SRY and SOX9. So SRY and SOX9 expression on bipotential gonad will lead into development of testis. So this bipotential gonad under the influence of SRY and SOX9, it will develop into testis. Whether for the development of bipotential gonad into ovary, it should be expressed by WNT factors like WNT4, beta catenin and RSPO1. So for the development into testis, SRY and SOX9 are needed, whereas for the development into ovary, WNT4, beta catenin and RSPO1 expression is needed. WNT4, beta catenin and RSPO1 expression for the development into ovaries, but SRY and SOX9 for the development into testis. Okay, these are the factors. So why I am telling is, any of the deficiency in these factors or mutation in these genes like WT1 or SF1, if the mutation is in the WT1 and SF1, there will be complete absence of the bipotential gonads. Okay, there will be complete gonadal dysgenesis. There will be no ovaries and no testes. Okay, if there is absence of SRY and SOX9 expression in male child, the genetic phenotype will be W46X9. Okay, because in female child the SRY and SOX9 expression will lead to the development of testis. In male child, the SRY and SOX9 male child 46XY, the genotype of the male child is 46XY. In 46XY genotype of the male child, the SRY and SOX9 expression will development into testis, whereas in 46XX these WNT4, beta catenin and RSPO1 in W6XX female, it will lead to ovaries. But if there is WT1 and SF1 absence, there is complete absence of the bipotential gonad and there will be no formation of any gonads. If in male child, if SRY and SOX9 expression is there, expression is defective, the genetic defect will be 46X9. For the genotype will be male genotype, but there will be no production of the testosterone because there will be no testis. Okay, for the development of the testis, these genes are important. In the next video, where I will discuss about different case scenarios, if these genes are deficient, what is the phenotype and what are the clinical features, I will tell you. Okay, if there is SRY and SOX9 is deficient, it is, or WT1 and SF1 is deficient, so in male it is called Swyer syndrome. Okay, there will be gonadal dysgenesis, complete absence of the gonads. This, though the genotype is male, he will be appearing as the female child. Okay, until puberty you don't know that he is a male. Okay, okay. So SRY and SOX9 are important for the testicular development in the female child. Okay, in male baby with testis, testosterone is produced which stabilizes the Wolffian duct. So in male baby, testosterone is produced from the testis which stabilizes the Wolffian ducts. So this testosterone produced from the testis will stabilize the Wolffian structures. Wolffian structures are as different seminal vesicles, epididymis. So first, when this SR1 SOX9 expression is done, the testis is developed. From the testis, the testosterone is produced, which will stabilize the, which will helps in the formation of these Wolffian structures. As different seminal vesicles and epididymis. Okay, and also from testis another hormone is produced, Anti-Mullerian hormone. This will help in the from the testis is produced. This will help in the inhibition of the Mullerian development, Mullerian structures. So Mullerian structures will be inhibited by the development of the Mullerian structures will be inhibited by the Anti-Mullerian hormone, Anti-Mullerian factor produced by the testis. Okay, the two hormones are produced, testosterone and Anti-Mullerian factor. Testosterone will help in formation of Wolffian ducts, that is vas different seminal vesicles, epididymis, whereas Anti-Mullerian factor will help in the inhibition of the Mullerian development, Mullerian structures, that is uterus and fallopian tubes. Okay, in female fetus, as testosterone is not produced, will not form Wolffian structures. Okay, in females, because testosterone, ovaries will not develop testosterone, produce testosterone, local testosterone. That's why in female fetus testosterone is not produced, because from adrenals there is some production of testosterone. Okay, but this will not act on the in the development of the Wolffian structures in females, because for the development of Wolffian structures like mass difference, there should be local production, paracrine production, means locally in the genital area only there should be production of the testosterone. Only locally paracrine production of the testosterone will only helps in the development of the Wolffian structures. Okay, so in female fetus this local development of the testosterone is not there, because the gonads are ovaries which will produce estrogen. So this testosterone produced from the testis will not produce the this testosterone will not be produced in the females. That's why the Wolffian structures are not formed. But because AMF, Anti-Mullerian factor, is also not produced in females because there is no testis, so the Mullerian structures are not inhibited. Because it's not produced, AMF is not produced, Mullerian structures are not inhibited, and they are produced, they are formed, they are not inhibited. So Mullerian structures like uterus, fallopian tubes are formed in the females. In males, because testis is producing testosterone and AMF, the Wolffian structures are formed and Mullerian structures are inhibited. Because in females testosterone is not produced, Mullerian structures are stabilized, they are formed, Wolffian structures are not produced. Okay, by 13 weeks of gestation, this is very important. By 13 weeks of gestation, the internal genitalia are formed. They are formed, internal genitalia are formed, and external genitalia differentiation is also completed. Means the internal genitalia like uterus, ovaries, everything is formed. Okay, and external genitalia like there will be differentiation will be done. Like in males there will be presence of testes, in females there will be presence of so differentiation will be done. Means external differentiation means there will be labia and scrotum, so external differentiation will be done. And internal genitalia also formed by 13 weeks of gestation. So there will be differentiation. If you see the fetus ultrasound, we can say that this is a female baby and this is the male baby by external genitalia by 13 weeks, and also internal genitalia also formed. Okay, beyond 13 weeks only conditions present are testicular descent, external genitalia enlargement. Okay, external genitalia growth occurs. So beyond 13 weeks, only things which are pending is testicular descent should be done from the abdomen, from the inguinal area. Testis will descend into the scrotus. So beyond 13 weeks, testicular descent and the growth of the external genitalia. In females, in males there will be growth of the penis. Okay, and also, so any defect beyond 13 weeks, so any defect beyond 13 weeks will not affect internal genitalia. Okay, will not affect internal genitalia and basic sex morphology. Only defects seen are micropenis, because penile development will occur only after 13 weeks. Micropenis, undistended testis, because testicular descent also occurs after 13 weeks. And hypospadiasis in males, and clitoromegaly, labial few. So in males, because if anything like androgens in congenital adrenal hyperplasia acts on the females, so they will cause the clitoromegaly, because it's called virilization. Clitoromegaly, labial fusion, rugosity of the labia in females. Virilization can occur beyond 13 weeks if there are excess androgens like in congenital adrenal hyperplasia. These can occur, whereas in males, if the beyond 13 weeks, if there is any defect, then there can be micropenis, undistended testis, hypospadiasis. Hypospadiasis means the urethral position will not be in the tip of the penis. Okay, there will not be in the tip of the penis. It will be in between the penile phallus, or it will be in the scrotum. Okay, it's called hypospadiasis. Means hypospadiasis means the urethral position will be in the it is in the mal position. Okay, so beyond 13 weeks, only these defects can be seen, like undescended testes, because already internal genitalia and external basic morphology is formed below before 13 weeks only. So beyond 13 weeks, the size of the penis and descent of the testis, like micropenis, undescended testis, hypospadiasis in males. Whereas if the excessive androgens or influencing the females, then it will lead to clitoromegaly, labial fusion, rugosity of the labia in females. Okay, virilization in the females. In first trimester, HCG acts on LH and HCG receptor. Okay, drives testosterone synthesis. So in first trimester, on LH and LH or HCG receptor, that is in gonadotropin receptors, HCG is acting. It's LH and FSH are not produced in the first trimester. Basically, LH and FSH are the not gonadotropins in the action. HCG is the gonadotropin in the action, which acts on the LH gonadotropin receptors is HCG, not LH or FSH. Okay, so HCG is the main gonadotropin in the first trimester. HPG axis activation occurs by 16 to 20 weeks. That is, LH and FSH are main gonadotropins in the action only after 16 to 20 weeks. By that time, HCG is the main gonadotropin action. So, in conditions like hypogonadotropin, hypogonadotropic hypogonadism, like where HCG, LH and FSH are deficient, these conditions will not affect before 16 to 20 weeks. These conditions will not affect before 16 to 20 weeks. So, in hypogonadotropic hypogonadism, by the time 16 to 20 weeks, by the time these LH and FSH are active, I told you already the 13 weeks, the internal genitalia are formed and external the basic differentiation of external genitalia is done. So, if any deficiency in this LH and FSH, that is in hypogonadotropic hypogonadism, will not affect the internal genitalia or basic sexual orientation, as gonadotropins work only beyond 13 weeks. Okay, before 16 to 20 weeks, the gonadotropin in action is HCG. So, after 16 to 20 weeks only, LH will act. So in hypogonadotropic hypogonadism, because these basic external genitalia differentiation and the internal genitalia formation occurs before by 13 weeks, so they are not affected in hypogonadotropic hypogonadism. Okay, and adrenal androgens, I already told you, adrenal androgens like the dihydroepiandrosterone or testosterone produced from the adrenals will only affect the external virilization. Okay, only external virilization, external appearance will be affected, external genitalia growth, external virilization will be affected, but these do not affect the internal genitalia, as internal genitalia are differentiated, developed by the pre-paracrine action of the testosterone. So I already told you in before that internal genitalia formation is done only with the paracrine action of the testosterone. The adrenal androgens will not affect that internal genitalia formation, only they will affect the virilization. Okay, ambiguous genitalia are not seen in chromosomal defects like Klinefelter and Turner syndrome. In Klinefelter and Turner syndrome, the external appearance of the genitalia is basic differentiation is present. Okay, in Turner and Klinefelter. Like in Klinefelter, the penis is present is because is for male, penis is present, testis is present, but only the size of the penis and testis will be small. Whereas in Turner syndrome, she is a female with normal external genitalia. Okay, so there will be no gross difference in the external genitalia. There is no ambiguity in the external genitalia in these chromosomal defects like Klinefelter and Turner syndrome. Okay, now we will come to the I will just make you the summary. Just normal physiology we discussed till 6 weeks, that is bipotential, and this bipotential with SSRY and SOX9 it becomes into male, and WNT4 and beta catenin it will become into female. So in Swyer syndrome condition in 46XY, this SRY and SOX9 are expression is defective. This will lead to the Swyer syndrome, which is the complete gonadal dysgenesis. Testosterone will help, testosterone from the testis will help into the formation of Wolffian ducts, Wolffian structures like Malphian vas deferens, seminal vesicle, epididymis, whereas anti-Mullerian hormone will inhibit the Mullerian development, uterus and fallopian. Whereas in females, this testosterone is not formed and AMF is also not formed. The Wolffian structures will not be formed, but Mullerian structures will be formed. By 13 weeks of gestation, the internal genitalia will be formed and external genitalia differentiation is done. So any conditions which affect beyond 13 weeks will, like for example, I told hypogonadotropic hypogonadism, because HCG is the primary gonadotropin before 16 to 20 weeks. These hypogonadotropin, this is the deficiency of LH and FSH, hypogonadotropin hypogonadism will not affect before 13 weeks. So there will be normal internal genitalia and hypogonadotropic hypogonadism. Okay, and adrenal androgens will not affect the internal genitalia formation. Because only paracrine locally produced testosterone will be affecting the internal genitalia. Okay, now we will come to the DSD definition. DSD is a congenital condition in which development of chromosomal, gonadal and phenotypic sex is atypical. So chromosomal example is Klinefelter and Turner. Gonadal and phenotypic sex is atypical. Okay, external appearance will be atypical. In gonadal also sometimes there will be ovotesticular. So the chromosomal and gonadal, and sometimes in gonadal like ovotestis will be present. So chromosomal, gonadal and phenotypic sex is atypical. Okay, phenotypic means external appearance. So anything chromosomal, external appearance, external genitalia appearance, and gonadal internal genitalia appearance is not developed properly, then atypical, then it is called DSD, disorders of sexual development or ambiguous genitalia. Okay, dihydrotestosterone is mainly involved in the masculinization and growth of the external genitalia. Okay, dihydrotestosterone mainly helps in the male virilization in the males, that is formation, growth of the external genitalia, and for secondary sexual characters like secondary sexual like pubic hair and beard, mustache, and also change in the voice, All these things will be and virilization of the genitalia will be done by dihydrotestosterone. It will act on the external genitalia and on the secondary sexual characters, so it does not affect the internal genitalia. So its deficiency due to defect in 5-alpha reductase will also leads to DSG, because its deficiency, because in 5-alpha reductase deficiency, the 5-alpha reductase helps in conversion of testosterone to dihydrotestosterone. If 5-alpha reductase deficiency is there, then dihydrotestosterone is not produced properly, and this will lead to the, because the virilization, I told you dihydrotestosterone is needed for the virilization and growth of the external genitalia. So when it is not present, they will be having a small penis, and sometimes testes will not be descended, and sometimes the labial fusion will not be correct, because this dihydrotestosterone will help in the correct formation of the external genitalia. If it's not deficient in males, the external genitalia sometimes will appear as the females. This is called, so in 5-alpha reductase deficiency where dihydrotestosterone is present, it may also lead to ambiguous genitalia. Now we will come to the class. We have seen definition. Now we will come to the classification of DSG. It can be classified into sex chromosomal DSG, okay, and 46XY DSG and 46XX DSG. Sex chromosomal DSG, it is two types: Klinefelter syndrome and Turner syndrome. Klinefelter syndrome is 47XXY and Turner syndrome is 45X. And in 46XY DSG, this is a male genotype, but because of the disorders of testes development, like gonadal dysgenesis or Swyer syndrome, I told you before, if SRY gene or the SOX9 or WT1 gene are defective, the complete gonadal dysgenesis, also called as Swyer syndrome, will appear in male 46XY DSG, where the testicular development is impaired because some genetic factors like SRY, if it is not there, then it will lead to Swyer syndrome. Disorders of testosterone synthesis or dihydrotestosterone synthesis, like 5-alpha reductase deficiency, hypogonadal 5-alpha reductase deficiency or hypogonadotropic hypogonadism. In these conditions, because external genitalia, I also told you, because dihydrotestosterone is not formed, external genitalia virilization will not be formed, and it can be appeared as ambiguous genitalia with micropenis, improper fusion of the scrotum, okay, all these things will be seen. Disorders of testicular action. So for the testicular action, the receptors should be properly acting. In complete androgen insensitivity syndrome, there will be defect in androgen receptors. This will lead to complete androgen insensitivity syndrome, okay. So in 46XY DSG, there will be three conditions. There will be disorder of testicular development, like Swyer syndrome, complete or disorders of testicular synthesis, 5-alpha reductase deficiency, disorders of testicular action like complete or partial androgen insensitivity. And next is 46XX DSG. Here there can be ovarian dysgenesis can also be seen, like in factors which producing bipotential gonad like WT1 or I told you here, bipotential gonad SF1 WT1 will influence the bipotential gonad. So if these are deficient, there will be no formation of the ovaries, the gonadal dysgenesis. Next, androgen excess. Like in congenital adrenal hyperplasia, there will be androgen excess, which leads to virilization of the females, okay. The external genitalial appearance will be like males. There will be clitoromegaly, fusion of the labia, scrotal rugosity, all these things will be seen because of the excess androgens. Next is in some conditions there can be amenorrhea or delayed puberty, like in hypogonadotropic hypogonadism or Mullerian agenesis. Okay, so in hypogonadism and Mullerian agenesis, there can be amenorrhea and delayed puberty. So these are the different conditions can be divided into ambiguous of DSG. It can be broadly divided into three columns: sex chromosome DSG, 46XY male DSG, and 46 XX GSG. In sex chromosome DSG, Klinefelter syndrome, here there will be defect in the chromosomes. I already told you, congenital condition where there is defect in chromosomes or defect in gonads or phenotype. So here the chromosomes are defective. No, instead of 46XY or 46XX, here in Klinefelters it is 47XXY and Turner's 45X. Whereas if the chromosomes are not normal but gonadal development will be, so I already told you, gonadal development also is called, problem in gonadal development is also called as DSG. So here the gonadal development, testicular development and ovarian development is not there. In 46XY, Swyer syndrome or complete gonadal dysgenesis, or sometimes phenotypic problem will be there because of testosterone synthetic defects or testosterone action defects because of some enzyme deficiency or because of the receptor deficiency can also lead to the problem in this. For normal chromosome will be there, but because of primary gonadal or hormone deficiencies it can lead to ambiguous genitalia. Here also in females there will be chromosome 46XXGSC, chromosomal will be normal, but due to gonadal failure or because of sometimes because of androgen excess like in congenital adrenal hyperplasia, the adrenal androgens will be excess. So this can affect the females normal chromosome, females with normal chromosome with excessive virilization. So this is basic classification. In next video we will discuss about each case scenario of each DSG. Okay, like we can discuss the case scenario of Klinefelter, will discuss about Turner, we will discuss about Swyer syndrome, we will discuss about alpha reductase, we will discuss about complete androgen insensitivity, we will discuss about partial androgen insensitivity, we will discuss about congenital adrenal hyperplasia, Mullerian agencies. We will discuss all these things as case scenarios, their clinical features and everything in next video. Thank you for watching my video. If you like my video, please press like button and subscribe to my channel.